In 2026, omeprazole remains a key medication for treating acid-related conditions. Its reputation is based on its potent and irreversible inhibition of the proton pump, which objectively outperforms H2 blockers. However, doctors often labor under the illusion that prescribing omeprazole automatically means the disappearance of symptoms, ignoring the high percentage of patients who do not respond to therapy. Where it works, the molecule is the gold standard for healing peptic ulcers. Treating Zollinger-Ellison syndrome and erosive GERD, omeprazole provides sustained acid suppression. Long-term maintenance therapy, even for years, is effective and safe. It controls reflux esophagitis without increasing the risk of cancer. Although moderate mucosal changes are possible in elderly patients, exceptions where the illusion fades. The biggest clinical mistake is to interpret any heartburn as an indication to increase the dose of omeprazole. The 50 failure phenomenon, up to half of patients with GERD do not achieve complete symptomatic relief. This is not due to the drug's weakness, but to esophageal hypersensitivity or the non-acidic nature of the heartburn. In these cases, pushing acid suppression further is futile. Dangerous combinations. Physicians continue to underestimate 450 Cypriot pounds interactions. Omeprazole inhibits the metabolism of Clopidogrel, reducing its antiplatelet effect. Despite known warnings, this dangerous CO prescription remains common. Hidden risks. Real-world clinical practice reveals an increasing incidence of renal disorders associated with omeprazole, a fact often overlooked during routine monitoring. Clinical effects. Diagnosis review. If a patient with GERD does not respond to the standard dose, do not automatically double it. Rule out visceral hypersensitivity or functional heartburn. Omeprazole is ineffective in these cases. Cardiac safety. In patients taking Clopidogrel, omeprazole should be avoided in favor of PPIs with less impact on CYP2C19, such as pantoprazole. What changes should be made in practice starting tomorrow? Stop treating resistant heartburn solely by increasing the omeprazole dose. Look for non-acidic causes. Implement strict control of prescriptions in cardiology patients. The omeprazole plus Clopidogrel combination should become taboo. Include renal function in the monitoring plan for long-term use of the drug. Omeprazole is a powerful acid-suppressing agent, safe regarding carcinogenesis, but ineffective in 50% of patients with GERD due to hypersensitivity mechanisms that it does not affect. Its thoughtless combination with Clopidogrel and the disregard for nephrotoxicity remain the main areas of iatrogenic risk.